Good morning, everybody. Thanks for joining our webinar this morning on how to care for paediatric patients, particularly on the manual handling front. Carole Johnson is our visiting guest speaker today. She is a physiotherapist and has got many years of experience in manual handling specifically, and has had a lot of experience with dealing with paediatrics. So I will hand over to Carole.
Right, good morning everybody. Fantastic to see such a lovely crowd, and I hope you don't get too hot today with the weather and the temperatures that are supposed to be soaring, I think. Thank you, Harvey, for that introduction. And I've worked with children for a long time, never meant to. I worked with adults originally, but was asked to go and investigate a situation in manual handling with a child and got very absorbed and love working with children. I hope you do too, and I hope that the session gives you some good tips and discussion points. So just at the start, one of the hardest things about doing something like this is that we're talking at a distance and we're talking about complex situations. So we do need to be careful with each other. And one of my little rules that I have is, if you're ever tempted to sort of sit there and think, oh, I can't believe they've just done that, that's horrendous. None of us would ever dream of doing such a thing. Please take it in context, and also bear in mind that we're human beings. One of the toughest things about manual handling is it's such a fluid subject, and we all like to have rules and systems that we work by, and sometimes we have to stretch those rules. We have to work in particular situations. So let's be as open-minded as we can. Obviously, none of us wants anybody to be hurt. Nobody wants a child or a member of staff to be injured. So there's a lot of things to think about. Also remember that with children, one child is very different to another, even if they've got the same condition. So where we can use our experience to give us a sort of a more holistic view, we do have to remember that just because one child with cerebral palsy has got high muscle tone, the next child with cerebral palsy may be completely at the other end of the spectrum. So we must be careful about over-labeling. Also, I've discovered in this field, we do need to be aware of the obvious. And I'll give you an example. I know it's not a child-related example, but my mother had a stroke last year, and we've had lots of lovely input from professionals. And we put the bed rail on her bed on the easiest side so that she could get in and out of bed, get there with her frame. We tested it all, and then discovered that my mum was abandoning the frame in the hall, and we couldn't understand why. So I asked her to talk me through the process, got her to show me what she actually did. And the big thing that we'd missed is, to go to bed at night, she needed to shut the curtains, which were the other side of the room. She couldn't get her frame round the bed, so she was abandoning the frame and getting in on the side of the bed without the rail, which was causing her difficulties. It was so obvious, I can't believe I missed it. But we sometimes do have to get people to talk through, demonstrate, and to show us those things so that we don't miss the obvious. So what's the difference between handling children and handling adults? Well, you'd think that I would say size and weight, but I think my biggest child at 15 was 22 stone and 6'8". And it definitely caused us some good thinking processes to have to go through there, especially as he would put himself to the floor and needed to be got up. So we can't say that it's size, because they could be very big, they could be very small. But what are the differences with children? Well, one of the things that I found is, whereas, and this might sound a little bit harsh, but with children, we've got that feeling that they've got the whole of their lives ahead of them, that they're still developing, and we're all desperate to give that child that best opportunity. So people will take risks that maybe they wouldn't take with an adult. They're at the beginning of their journey. Another factor is that you have potentially a lot more people involved in the care. You've got parents' opinions to take into consideration as well as the child's. You may have multiple therapies that are involved. You have a school that's involved. So there just may be loads more people to take into consideration. Some of the conditions they have are going to be different. The child hasn't fully developed. They're still doing that developmental process. And the child themselves may change. So a very compliant 6-year-old that's delighted to be lifted, manually lifted, or even hoisted for a personal care situation, they get to be a teenager and suddenly they don't want that same person with them, that person that's known them since they were a small child. They may become a teenager that doesn't want to talk. Just because they have a disability doesn't mean to say that they're not going to go through all of those same things that any other teenager would go through. So there are a lot of things to think about with children. Sometimes people find it very scary because they feel that they have to do what the child wants because it's such a complicated situation. And from time to time, just as those of you have your own children, sometimes you have to say, no, it isn't happening. It needs to happen this way. And that's something else that you may not be doing with an adult. They may decide to take a set of risks and you go, okay, you've decided to take that set of risks. For a child, we have a responsibility for their well-being and their ongoing safety. It is a little bit different. There's lots more differences that we could discuss, but those are just some little ideas. I don't know how it's been for you in this current situation, but I haven't had a more unusual problem that I hadn't really anticipated with working with children. Children are very used to staff in PPE, and they are happy to see gloves and aprons, and it's not a problem. I have, over these recent months, come across issues with staff wearing masks where they hadn't been wearing them before. And especially for children that are needing that facial input, that visual input, the masks has posed a little bit of a problem. In addition, we have to bear in mind that children may grab the masks. We have to consider, is there a strangulation risk? Are they going to pull it and pull it tight depending on the sort of mask that the person is wearing? And very simply, we also have to think about those children who may have coughs and colds and sneezes and sneeze all over us as we're doing the manual handling. And that may be now an extra consideration that we need to think about. We need to know the child that we're working with, and that cannot be overestimated, really. We have such pressures on our time that we want to go in, come up with a solution, and walk out of the door having created a lovely answer. But time is the big thing that we need. We need to spend that time with that family. Remember, they potentially have so many professionals coming in, different professionals, and we have to factor in that we're yet another person that's walked into their lives with our strong opinions. We also have to think about the fact that children are on the whole very trusting. I hoisted my son for the first time. He's now 30, almost 30, and I hoisted him for the first time at the age of 6. And I shall never forget, I tried to explain to him about the hoisting process and what happened. And afterwards I asked him, how was it for him? How did he feel? And he said, yeah, well, I trusted you that you weren't going to choose a wrong sling or do something bad to me. Of course you were going to look after me, but you didn't tell me enough about the process. You didn't tell me that I was going to be leaning back. You didn't tell me how quickly it would go up. So children will trust us. They will assume that we don't want to harm them, but sometimes we don't fully explain to them exactly what's going on. And sometimes we need to explain that every single time we hoist them or maneuver them. And we can easily get into the habit of, right, we all know what's happening. We don't need to talk. We have to keep talking. Do a lot of talking with the children that I work with. As I've said, we think of manual handling as our top priority. It's what I do day in and day out. I can fill my day with manual handling. I can fill it, making it the most important thing. But the family, it isn't the most important thing. It is another thing they have to take into consideration. They want to get the children to school. They've got other plans that they want to do. And if we then introduce techniques or systems that take them another 20 minutes, they then may abandon them because it's just not going to work. We may focus on the mantra of, well, we've got to prevent injury. We've got to save your back. You've already told me you've got back pain. But that isn't their only worry and concern. The other thing to bear in mind is that the parent has had the child from the start. So they had them when they were really tiny. Yes, okay, now they may be much bigger, but they had them from the outset. They could gradually build and get stronger to manage that child, whereas we or staff are walking in off the street, having to deal with that situation. Also bear in mind, we can sometimes be seen as the bearer of bad news. And we are the people, if you're coming in with a manual handling hat on, we are the people that come in and say, you can't do that. You have to use equipment. And that gets us off onto the wrong foot. If you want a really good book to read, I'll just hold this up for you. The title is The Manual Handling Revolution. It's by a lady called Aideen Gallagher, and you may have come across it. But it really explains how families, how people may view us coming in as the professional, and gives lots of great ideas about how we can deal with that and how we can sort that out. It's a really good book if you can get hold of it. Very easy to read, very, very sensible. One of the things that I have tried to move away from over the years is just presenting my opinion or my experience. If you've been working in the field a long time, you've seen lots of children with cerebral palsy or lots of children with different conditions, you can go, ah, yes, I know how this works. The child will start off being able to stand or not being able to stand, and they're going to progress along this trajectory. We need to be so careful that we are not putting our experience as the main factor in a situation. It can be so easy for us to say, well, obviously, we're going to have to put a hoist in. That's how it's going to be. Let's save time. Let's get that hoist set up. Whereas we haven't allowed the family to get used to that idea. And we may not be right. I had a classic situation. One of the first schools I ever went into, we had a young child who was very floppy, very low toned, couldn't even hold her head up. She spent a lot of time crying, and everything seemed to be really quite dire. We couldn't work out why she was crying. So I persuaded the school to put in everything. We had overhead tracking hoist, and this is a long time ago. So overhead tracking hoist was very expensive, complicated to get in. We had up and down change tables. We had everything. 3 months later, the Senko phoned me and said, you've got to come back. My first thought was, how on earth can this situation be worse? Arrived, and this little girl now had head control, sitting balance, and was able to crawl on the floor. I was not expecting that. I had decided, from my professional opinion, that we had a child here that was going to need maximum help all the way along. It was such a fantastic moment in my career to see this little girl crawling along the floor, and taught me a very important lesson. So the use of metrics. To start with, lots of listening and observing will just help you decide what metrics you need, because they are variable. And I know that Felgains, you have done some webinars on using tools, so I'm not planning to go through those potential tools here. If you want some examples of tools, then you've got the manual handling of children. Second edition, we're hoping, is going to come out later on this year. But that gives you lots of tools that you could use. So time may be a factor. It might be the weight of the child as a factor. It might be pain. It might be comfort. But discuss with the family or with the people that you're working with, what is it that you're concerned about? For example, somebody might say, well, I'm not having my child moved with any technique that increases their pain, just not having it. So you could say, okay, so let's score this. You're currently manually lifting them. If you can ask the child, how comfortable was that for you using a Leica 1 to 10 scale? If not, you'll have to find another way of doing it. You could say to the parents or the carers, how do you decide how much pain the person is in, the child is in? And they'll say, oh, well, for a manual lift, I'd say they're really comfortable. It's an 8, it's a 9, where 10 is the best. And you say, okay, so what level would you be prepared to accept? And they go, oh, not less than that. Has to be 8 or 9. So you can say, okay, we've got something to work to. Let's choose techniques that will come out at 8 or 9. That's using a metric. It's not you going, oh, well, he looks happy to me, while the member of staff is going, oh no, he's really, really unhappy. Use a metric, use a system to help you quantify that rather than just your own personal judgment. It might be that the family say want a quick move. We can't hang about. We've got 4 children to get to school. It might be that the carer is worried that she's already got a bad back and she's concerned that picking the child off the floor is going to make that worse. This is something that my husband introduced to me, and he called it acceptance criteria, and I find it fantastic. So what is the acceptance criteria for this task? What are you prepared to accept? What are you prepared not to accept? And getting agreement on that and using the tools to get that agreement is a fantastic way of detaching the emotional element, but while listening to everybody's opinion and taking that on board. We do have to discuss the behavior aspect. So what happens if you're trying to do the manual handling, you're trying to transfer the child, and classic, in my early days again, the teacher said, watch out, she bites. Okay? And I just thought, she looks lovely, she's a sweetie, she's never gonna, why would she bite me? While I was thinking that, she bit me. Now, why did she bite me? That was the bit that interested me. Was it because the teacher said, watch out, she bites, because there was nothing wrong with her hearing, and she thought, well, yeah, let's see how we respond? Was she thinking, I don't know this lady, I'm scared, and I'm going to bite her, perhaps she'll go away? And it got me really interested in thinking about that side of things. She was bored, she thought it was funny. She'd heard the teacher, we established that over time. I had another young lady who, the first time I met her, the head teacher said, just to warn you, she screams at anybody that's new. Don't worry about it, we don't take any notice, it's not a problem. I was sitting next to her in the corridor waiting to go and do the assessment. She came in her powered wheelchair and sat next to me. She stuck out her tongue at me. What do you do if a child sticks their tongue out at me? Now, you might criticize me and say, Carole, that was bad form for what I did next. But there I was in a situation, I had a decision to make. Was she going to start screaming at me? So I took a decision and I stuck my tongue out back. Was it the right one? Was it not? Well, the next bit hopefully will solve that for you. The head teacher came in just as I was sticking my tongue out. Bad move. That was not a good moment in my life. She looked horrified at me. I thought I'd employed a professional person, and this is what I walk into. She didn't say anything. We went off and did the assessment. And at the end, she said, I'm not going to ask what that was all about. The only thing I can say is you are the first person she has never screamed at. It could have gone wrong, couldn't it? It could have been terrible. I could have got myself into such hot water, but I had to make a decision. Thank goodness I made the right decision. Why was she doing it? She was raising a challenge. She was saying, right, let's see what sort of adult you are, because she was expecting me to say, now, young lady, this is no way to behave. We're grown up here. We behave like adults. We don't do that sort of thing. And then she would have screamed. because that was what she was expecting. By me doing something different, threw her off guard, and she decided that perhaps I was going to be okay. So think about a child's behaviour. Why are they doing it? And try and analyse that. Now, you know, looking at the dementia book, and I know Mel did a session, there's lots of stuff on behaviour there that actually is very helpful for children too. But obviously I'm not going to stray too much into that just now. So let's move on. Equipment. One of the things about manual handling with children is the equipment can be quite different. You have standing frames. You have you all come across the equipment called an UPSI? Now, again, some people think that's amazing, and some people think that's the most non-therapeutic piece of kit. It doesn't matter. That kit is out there and it serves a purpose. You've got wheelchairs that come into a standing position. You've got ladder back chairs. You've got peanuts. You know, the first time I said to somebody, oh, can you go and get me a peanut? And they went, we have a policy in the school of no nuts. And you go, oh no, sorry, okay, it's and then explain what it is. So we use terms that to other people are strange and weird. We use achiever beds, we use therapy balls. There's all sorts of different pieces of kit that you don't necessarily get with adults. Obviously, we can't go into all of those bits of kit today, but definitely keep your eyes open. And when we can all start moving around again and going to product shows, have a look, have a play. And if you can get a child involved, I used to get my children to try equipment out. They're now a little bit old for that, and the grandchildren are not quite so easily got hold of. But when I can and when they're willing and when it's safe to do so, I do explain manual handling equipment and show them and get their take on it. So Harvey, we're going to move on to some of our scenarios now, because I think one of the best ways of looking at manual handling is to pick true stories and to analyze those and go through them. So
if Carole talks us through the first scenario, we will get ourselves ready to send.
Okay, thank you, Harvey. Right, we've got a lovely willing volunteer, Fergus. Now, we need to look after him. He hasn't been manually assisted before, so this is a new experience for him, and I want to make sure he goes through the rest of his life being quite happy with being assisted to move. I don't want to put him off, so we do need to look after him. Now, please do cut us some slack as we're doing this. We're trying to create a scenario in an unreal situation, so do bear that in mind. But this scenario is about rolling, and I'm hoping this will generate a little bit of discussion. So what we have here is a young child who has become resistant to being rolled. They've got high tone, and they've recently had their medication changed, and that tone unfortunately has increased. So by high muscle tone, what I mean is that their muscles and joints end up feeling stiff when they move. They don't move very easily. What we have here is we had a difference of opinion between staff. So there was a group of staff that said the reason that rolling has become difficult is because of the change of medication. There was another group of staff who said, no, it's got nothing to do with the medication. It's got to do with the fact that she doesn't want to go to maths and she doesn't want to go to bed. So she stiffens up to avoid that movement. Another member of staff said, no, it's neither of those. It's because one day I yelped when I was rolling her because I got a pain in my back and she thought it was funny. So she's trying to get that to happen again. The fourth set of opinions was that the child was bored and rolling was part of her therapy program and she was bored with that and it was repetitive and uninspiring. So we've got to unpack that. So let's start off with how it worked. So when staff were rolling, they were rolling the child towards them. So Harvey, right, there is Fergus in bed and he's got to be rolled towards you. Now we could discuss height of the bed, and that will be an interesting one. How high do you have the bed? And how high do you have it if there's more than one of you? And quite often working with children, there are still two people. I don't know if people are finding that stress of being pressured into just using one person, but at the moment, traditionally, we are using two, particularly in personal care. So standard rolling rolls towards. So Harvey, could you please assist Fergus to roll towards you? Fergus, can you remember you're a little bit stiff and you don't want to move? Normally, obviously, Harvey would be talking to Fergus and explaining what he's going to be doing.
So I'm going to just roll you over now, Fergus. So there we go. Oh, you okay there?
So a standard roll, nothing too special. Now let's up it a little bit more. Let's do that again. Fergus, this time you're really quite stiff and you really don't like Harvey and he's really annoying you. Give him some trouble. Obviously, not so much trouble we get an injury on film, not so good.
Okay, so I'm going to try and bend this arm across. Oh, that's very, very stiff. That's very hard work. Right, I'm just going to roll you over now, Fergus. Oh, you okay? Why are you hitting me? That'll do.
Okay, now can you see, I love that. We couldn't have scripted that any better, Harvey. So what starts to happen? You start to see, Fergus, do get yourself comfortable again. You start to see all sorts of things coming into play there. So Fergus is starting to hit out, he's lashing out, it's becoming uncomfortable. Harvey is getting pinched, he's getting hit and pushed. The whole thing becomes difficult. Harvey's handhold deteriorates and he steps away. I know he wouldn't have done with a real patient, but you pull away and you don't want to be involved. So rolling towards, it's often what staff do. But why do we roll towards? Is there evidence that saying rolling towards is better for us? Could we roll away? Okay, so while I'm chatting, Fergus and Harvey, would you mind just popping in slide sheets? Now, don't worry too much about the technique for getting it in. We would, of course, do it all beautifully, properly. And if Fergus could get up like that, he wouldn't need all the assistance that we've been talking about. But just to speed things up. Obviously, there's different sorts of slide sheets and different systems available. We're just keeping it nice and simple here. Obviously, with children, we'd have a person on the other side or the rail would be up. But again, for purposes of needing to see, oh, you're going to pop it up for me. Thank you. Safety, absolutely. We've got to look after our people. But do you think that rolling away would actually solve part of this problem? So let's see, Harvey, off you go. Remember, Fergus, you've got a little bit increased tone. You're a little bit unimpressed. Okay, so obviously we're missing out quite a lot of steps here and we would be talking to our patient. There's all sorts of things we'd be looking at. But if, Harvey, you just stand next to Fergus for a moment in your finished position, we could now say that that might have solved the pinching and the pulling and the punching side of things. That's eliminated that issue. Also, it means that potentially you could work with less staff if it was appropriate. So you then got other options. Now, you're on a lovely bed there, Harvey. I'll hand over to you. Any further options that we could employ?
So a lot of the time turning is happening on shower benches, shower trolleys, that sort of thing, or standard beds. So this would be your go-to method of rolling away. The other option for turning in bed is what we've got here, which is the Venlet system. So if you roll onto your back again, I'll slice you down. So this is what we call a mechanized turning system. So we can use the system that's attached to the bed here to roll Fergus. So if I lift this side here, this is a a motorized roller bar that's attached to the sheet. So if I roll the sheet onto the roller bar now, that's going to turn over for me. So all I'm doing there is guiding the movement rather than doing any of the lifting myself. So that's another option if you've got a particularly difficult situation when it comes to moving and handling on the bed. Does that cover it, Carole?
Yes, thank you, Harvey. Now, you see, that's fantastic. You've eliminated a lot of prodding, a lot of pulling. The child is safe. Yeah, so if you can employ that type of idea, brilliant.
Have we got another scenario to go through?
Yep, yep, we can go through another scenario. Okay, if I tell you that the outcome for that story was that it was a little bit of the child and their increase, their change of medication that were causing some of the issue, but they were bored. So they needed to find different ways of keeping that child interested in what was happening and becoming creative, you know, possibly putting things on the wall, giving the child things to do. Getting the child to be part of the process rather than being done to. We do have a terrible habit of doing things to children. We hoist them, we maneuver them. A classic example is, do you let the child press the button on the hoist? Now I go into places where they go, absolutely no way, the child does not touch the buttons. I'll go into other places where they'll say, yeah, we do an assessment, and if they're able to do it, then they can use the buttons. If we really want our children to be heading towards independence, then we need to be giving them that as they're going along and not making them passive. So, second scenario. This is particularly a child, and this is where the peanut comes in. So a peanut, it's a big rubber peanut, and children will sit across it for balance work. Some schools have lots of them, some schools don't, but it's a nice, useful way of helping someone improve their balance. The downsides of them is that you definitely need two if you've got a child with low stability, and those two people can't get close because of the shape of the peanut. So you end up increasing their risk of injury and their stooping. So we have a child here. The backstory is that they were a group C, so a smallish child. The references are from the Manual Handling of Children book. Their FIM level, functional independence measure for sitting ability, was at 2, which meant they were doing under sort of 25 to 49% of the effort. So not terribly stable. He is held on the position, in his position on the peanut, and then you have one member of staff kneeling at the side or behind to support, and the therapist then conducts the therapy. The staff are reporting the perceived effort using the Borg scale at 17. So 6 is very light and 20 is maximal effort. And the staff themselves have classed the injury as a high risk manoeuvre. Therefore, it's now only happening once a week, which doesn't meet his therapy aims. So what we're going to look at is, can we improve his FIM score for sitting? So can we get him further along that scale and able to hold himself up? Can we reduce the number of handlers? And can we lower the risk for staff without increasing the risk for the student? So, Harvey, show us what you've got.
So,
cool.
I hope you can see this. Fergus is fully supported in the hoist. So he's sitting on the bed, but there's lots of tension going through the hoist there. I'm going to give him the control. Do you want to talk us through what happens?
Sure. There? So we haven't got a peanut here, so we're using the side of the bed, and maybe using the side of the bed is just as good. It will depend on your individual situation, but we're demonstrating here. So you now can reduce to one member of staff because the sling is doing the supporting. So Harvey could be sitting on whatever type of seating we work out is suitable. So it may be a wheelie chair, it could be some sort of stool. Again, you'll have to think that through in your own settings. The tension is taken up in the sling. So with Fergus at FIM level 2, he's going to need that full support of the sling. Now, for the purposes of our demonstration today, the sling doesn't have a head support. Obviously, if Fergus didn't have head control, you would have to have a sling with head support. But as you can see, he's holding his head up very well. So you can then get Fergus to do some activities in that position. Now, again, you might want Fergus's feet flat on the floor normally, or if the surface doesn't go down low enough, maybe pop them on a stool. Again, it depends what you're trying to achieve. But you could get Fergus to pass you things. So, lovely. You can get him to do some reaching. So maybe Fergus could pass you the pillow. Okay. So at the moment, he's fully supported by the hoist. So let's take off a little bit of slack. Let's make Fergus work a little bit harder.
Yeah.
So at this point, you can do all of those same things again, and Fergus has to work that little bit harder. Lovely. And obviously, for sake of balance, you would, in true therapeutic style, he would have to go to the other side as well to balance it all out if at all possible. So then finally, let's assume that Fergus is improving. His FIM level is now, you know, shot up the scales. He's doing amazing because this therapy can now happen every day and multiple times a day. And so now we take the slack off the sling completely, but we're not removing it. And that's what's lovely with this particular design. I love these types of hoists with children because you've got no spreader bar getting in the way. It's just fantastic. It makes a big difference, I found. So lovely to be able to have that as an example today. So now Fergus has to do all the work. But should there be a problem, there's still the sling there ready to take that support. And that was the answer we employed for that one. Worked very well, and the young man, his ability did improve where it hadn't before. So that's where we're talking about using metrics. We knew what his FIM level was at the start, and 1 year later his FIM had increased. So we've got a question, would it be feasible to do that with a mobile hoist? It would partly depend on the mobile hoist and the child. So if you've got a child with a lot of extension spasms, for example, I probably wouldn't do it with a mobile hoist. If they were more floppy and more predictable from that perspective, I might go for a mobile hoist, but it would depend on the make. I think you would have to look at the make and how the spreader bar is set up. If you've got ones with the spreader bar that are really arched and come over your head, that's probably quite helpful. I think you have to judge your child and your setting. But I'd prefer it to be with overhead tracking. That does make life a lot easier. In regard to funding of manual handling equipment, is this usually through social care, and do you run into difficulty getting the options you request? Oh, this is fantastic. Yes, I run into all sorts of problems, and quite often people are trying to pass the buck. So they say, oh, that's not my budget, that's somebody else's. We're supposed to be joined up for children. That's supposed to help. But everything's very tight, and it's obviously going to get tighter and harder. So the angle that I take is that I make a justification. So if I can say, you know, look, here's some evidence, here's the metrics that we're using, this is going to benefit you and benefit the child by, I put in my case. And sometimes I get it, sometimes I don't. If I don't get it, then I have to choose another option. Try and choose options that are going to keep the cost down, but don't go for your cheap option if that isn't going to be the thing that works. It is thinking it through, it's making your case. And I'm in a great position as an independent, because by the time I come on the scene, it is because there's been a disagreement, or there's been a lack of funding, or there's been some sort of stress that's added to the situation, and I'm being asked to come in to give a different view, to look at things differently. So that does help me from time to time. Sometimes it doesn't help me because they go, yeah, what do you know? You're just coming in from the outside. You don't know our difficulties and our constraints. But the biggest thing that I do is will make my case. And I'm very careful when I make my case to make sure that it is not that I'm making a case because I want it, that I'm making a real case and can provide that evidence. Are there any resources out there for parents who are lifting children following risk assessment? Do you know, my heart aches for parents. I think they get such a tough deal on the manual handling front. So many times I have been in situations where they say, fine, you lift them, you do whatever, but we can't let the staff do that. And you have this dual system that's completely unfair. I will work any way I can to get the parents their kit and equipment if I feel that it's going to be of benefit. I was going to say I'll beg, borrow and steal, but I won't steal, okay? But I will find all sorts of ways round if there isn't a formal system. And again, it's using my evidence trail. Sometimes I'll go to companies and say, look, we don't know if this is going to work. Can we just borrow one, just give it a go, and we'll feed back to you, and that will help you. Sometimes there's funds. I have great fun finding little funds that nobody knows about and going, oh, that's got £20 in it. That would buy a couple of this or that. Just get inventive. Keep looking, using social media, fundraising, go any which way. But I do feel that parents do have quite a hard job. And I do sometimes feel that there is this dual system and we don't look after our parents enough and from an early enough stage.
Thank you very much for coming on. Thank you everybody for joining us. And keep your eyes out for future webinars as they come up. Thank you very much, and we'll see you again another time.